Well, as with the Ph negative patients, age is still one of the most important negative prognostic aspects. This isn't so much the induction period. The vast majority of patients can achieve a complete remission, even if with only a kinase inhibitor without chemotherapy. And when I say without chemotherapy, I mean without systemic chemotherapy. It is mandatory to do a rigorous CNS prophylaxis to prevent central nervous system relapse. But maintaining that remission is difficult. Many patients relapse, and if you are too aggressive with the treatment, then you will have mortality. And of course, in an elderly population, transplant will be associated with an increased mortality. So straddling this is going to be critical. And as I said before, hopefully the combination of more potent kinase inhibitors plus other non-chemotherapy modalities, especially the immunotherapeutic agents, will be game changers. We have to prove this, but I think there is reason for optimism. We will obviously have to look at the long-term toxicity of these treatments as well, and we cannot only look at the response. Another interesting question, by the way, and one could say it is a challenge at the diagnostic level, is the modality or the method with which you measure minimal residual disease. At least in Europe, it's been the quantitative RT-PCR for BCR-ABL. So, but there is increasing evidence that the use of the immunoglobulin gene rearrangement assay, which is used traditionally for the Ph negative population, might give, in a subset of patients, diverging information, and it can go both ways. One can be positive and the other negative, and vice versa. It might reflect a different biology of disease subsets, and I think we will have to learn which of these methods yields the most relevant results in which situation, because if you make a therapeutic decision based on MRD, you have to be confident that the information provided by the MRD is correct and clinically meaningful.